Good morning, everyone. My name is Susan Kopp. I work on the IT team here at and I'd like to welcome you to our Phase 2 Contract IT Deliverable Overview training. This is the first of 2 meetings that we will be having to go over all of our 65 contract metrics that are related to IT. Today we have clinical IT representatives as well as our TDMC and our EHR members. I'm joined in the room today by our PMO staff and leadership team as well as our IT leadership team. Today we'll be going through, as I said before, the contract metrics. This is the first of 2 meetings that we're having. The second will be held on April 17th, and you will receive an invite for that. And we'll go through a little bit when we get to the agenda what those topics will be. So after this meeting, you will receive a spreadsheet with all of the contract metrics related to IT on it, and we've categorized them as whether they're report build, EHR build, or connectivity related. And that will be very valuable to you as you're planning the work that needs to be done for DISRIP. We want this meeting to be interactive. We have muted all your lines, but we will be using the chat box option, and we'll be monitoring that, and we will pause frequently to answer any questions that you may have. We'll also be available after the meeting if anyone would like to schedule some time with us to go over some questions that are specific to your organization. After this meeting, we'll be sending out all of the FAQs and also the recording for this meeting for your convenience for those who couldn't attend the meeting. For attendance tracking, please follow the link below and indicate the name of your organization as well as the attendees so that we can give you credit for attending this session. So our agenda today, we're just going to have a brief overview. Dr. Manjanoff's going to do our guiding themes and our performance activity categories and our metrics, and take on to discuss some HICNI connectivity requirements. We're identifying patient cohorts for registries and reports. Then we're going to focus on work that we've been doing extensively in our EHR subcommittee meetings for cardiovascular and asthma, and we've created roadmaps for those, and we're going to discuss those and how they tie back to the metrics. We'll then move on, as time allows, to our Domain 2 projects, which would include the PH2I and other metrics related to that. Then we'll leave time again for questions, and the next meeting is on April 17th, as we said. On April 17th, in our second meeting, we will finish anything that we didn't complete today for Domain 2, and then we'll move on to our behavioral health-related projects, metrics, and introduce our behavioral health roadmap that will be approved by the Behavioral Health Subcommittee. I'm going to hand over to Dr. Manjanoff now, and he'll take over from here.
Thank you, Susan. Good morning, everyone. Thank you all for joining with a very short notice. To take the opportunity to thank Dr. Roche for prodding us to have this meeting sooner than later. We're not planning on having this meeting until perhaps April, but certainly he really challenged us to see if we could have this meeting earlier, because he then can communicate the information from this meeting to his team, Albany Family Medicine. Again, Dr. Roche, thank you. I'd also like to take this opportunity to thank our partners who helped us to hit many of our 331 targets. Was quite a hectic month for March. April is not going to be any slower. We have quite a few deliverables in April as well, but I'm going to take this opportunity to thank our team as well as our partners to helping us to hit most of our targets for 331. And I'd like to take this opportunity to thank Susan Kopp, Chris Palmieri, Luke Papalizio, and Chris McIntyre for really helping us to put together this slide set, extensive slide set in a very short notice. And it was a weekend work with to try and get this webinar going for this morning. We may need to make some minor modifications to the content. We're waiting for the final document with final set of metrics. We'll have it by this evening or tomorrow. And by April 17th, we will have the most final set available for your reference. Obviously, we would like you to reference against your contract document. That's we will determine your payment. But this, what our hope is to have this extensive slide set we have prepared will help us to, to keep track of your deliverables, your activities. What as a disrupt entity, what we're trying to accomplish is to create an integrated delivery system. I mean, that's the underlying theme, and part of that requires a robust IT platform, IT solution, interoperable IT solution that's going to facilitate data sharing as well as other activities across our network. So we're asking, and we will certainly requiring, and as you look at some of these milestones, we want our partners to connect with Hixney as well as Shiny for to help us achieve one of the key components of the integrated delivery system, that's a robust interoperable IT system. So we'll work with you. If you're not connected, I'm glad I'm sorry. We all know that most of our partners, primary care partners, hospitals, as well as behavioral health partners are linked to Hixney. And there may be a couple of our partners who need assistance. We'll work with them to see how best we can help as a PPS, a PMO team, to help you all connected with Hixney, because that's critical for data sharing, as well as receiving alerts, bi-directional alerts as well. Underlying our work with COPE as well as our partners, and moving forward, there are two major areas that we will focus on. Obviously, the first and foremost obligation that we have for the members that we serve and DOH and CMS and our partners is how can, as an integrated delivery system working together, multiple organizations working together, how to provide better care so there is better outcomes, decrease in cost, overall increase in value, improve outcomes, less cost is what we mean value. How do we accomplish that? At the same time, to be able to work and to be able to do that, we need to be able to tap into all of the incentives that are available to us for the remaining 3-year period of work. And we put together these metrics working with COPE and internal teams. We also had significant feedback from our subcommittee members, so you will see some of these milestones may not come as new to you. But as you can see from the list of milestones we have sent, the number of milestones we have, EHR is a critical tool. The electronic health record system across our PPS is a critical tool to be able to help us achieve these objectives, to provide better care for our patients, timely care, proactive care, reaching out to patients when we need them to be engaged, as well as to be able to provide needed information to our clinicians and clinical team to be able to function effectively. And also for all of us to be able to track our performance. I think that's where EHR is very valuable too. For those objectives and for those reasons, EHR is a key critical component for our system, and that's one of the reasons why we've built in so many incentive metrics in around EHR. Some have direct EHR linkages, for other metrics. EHR is an important tool as well. So what we mean by better care, and you've all heard this before, you've seen talk about this before, but hopefully last time I want to just go over this slide again. Our team here are saying, oh, not mine, again, this is guiding team. But it's important for us to keep this reference as we go through our metrics. Most of the metrics, all of the metrics that we work with either somehow links with our ability to either provide better care, that increase access to primary care, behavioral and community-based services, provision of patient-centered evidence-based care, enhanced care coordination, care management. We're in the process, we've already contracted with mental health home care agencies to be able to provide this enhanced service. We didn't have that before, so this is a progress that I'm very proud of, and we want to continue to build upon it. Providing support for increased medication adherence that certainly has better outcomes as well as help us to hit many of our pay-for-performance targets. EHR and systems are critical for timely access to relevant clinical information as well as for effective communication and ongoing engagement of our members as well as our clinical team. High incentives, we want to maximize our domain one incentive. That's to some extent our guaranteed for the remaining 3 years, so we have to be able to submit the documents we need to and meet all of the milestones and requirements related to our process activities as part of this report. We now need to focus on pay-for-performance incentives. I was over the weekend looking at our measurement year 2 data that was just posted to that. It's almost final. I think we probably have hit about 40 to 50% of our pay-for-performance target. Many of them are for pay-for-reporting, so we'll certainly get those dollars. Even the ones that were pay-for-performance, I think we've done a fairly good job. We can do better, but as we go through measurement year 3 and 4, having these processes will be critical for us to hit those targets, and that's really where the monies are in the next 3 years. So I can keep talking about it. I'll hand over to Susan. Before we go to just to review our different 3 categories of metrics, as we have shared with you in the past. There's a set of metrics that are called prerequisite metrics. They do not have any incentives attached to them, but however, as an organization, if you're to receive any funds from for phase 2, you will need to meet these prerequisites. They're very straightforward, not too many of them, not complicated. We'll go. There's one metric related to EHR. Susan will go into shortly. There's sort of bundle metrics that you will have additional incentive, or you have the opportunity to earn additional incentive if you meet all of the metrics within a given bundle. Each metric will have its own set of dollars that will certainly achieve high incentives if you made the match all of them. As standalone, as I'll say, they're standalone metrics. You hit them, you'll get incentive for it.
Okay. Next, we're moving on to our HCSNE metrics, and as Dr. Manjanath said, it's very important. Our connectivity is very important for our integrated delivery system. So the first metric is what we call a prerequisite metric, and it's really to be able to receive funding for any of the other HCSNE-related metrics. You really need to complete this first. And that is signing the HCSNE agreement, which many of our partners that are eligible, and again, this is only partner type. If you look at this slide, I'll orient you to this format. It talks about the partner type, and it's the RIO eligible organizations. And it's the signed QE agreement. And the new part of this is the one-to-one exchange agreement, which is between the PS bank and partner organizations. This allows us to be able to utilize the clinical information that you're collecting on our attributed population. So this is really important, not only for us for analytics purposes, but also for our care managers who will be caring for patients across the PPS. The next one is so once we have the agreement signed, we need to establish bidirectional connectivity. So we are asking our partners to submit information to HCSNE and really to give us the identified screenshots that show that this is happening. And we will be sending out information based on your provider type. There are some state-required specifications that we will be adhering to, because I think, as many of you are aware, there are requirements from the state for real connectivity coming up within next year. The next one is subscribing to event notifications. This is really key, I think, to our integrated delivery system. Our care management providers are currently using this, as well as our primary care providers, and our centralized care management will also utilize these. These are based on admin, discharge, and transfer events and are very helpful in tracking patients throughout the PPS. And again, there's a partner type for all the RIO eligible organizations. And finally, the last one we talk about related to HCSNE is really demonstrating, especially for our behavioral health providers, they are utilizing HCSNE. They're looking for lab values and really showing that they can track their patients, because these patients interact with many different partners across our PPS. And next, I'm going to turn it back to Dr. Manjanath to talk about our cohort identification.
Sure, thank you. For many of the measures we require is to have, identify either the denominator or the cohort of patients that we would like you to provide us reports on. What we're really taking is a population health management approach. We're looking at the last bullet. What do you mean by population health management report? First and foremost, we need to know the population. That's really where the denominator or the cohort comes into play. Then we have a mechanism to identify what services those patients need, those members need. So, ability to create atlas and as well, to look at the population that need to some intervention, as well as ability to create alerts for clinicians to be able to act on when they have the clinical team, when they have the patient, and to be able to outreach to those patients when we need to. Lastly, tracking our performance. So what we're asking, as you look at your population, we want to identify a cohort of all metric eligible patients. So if you have patients with hypertension, if you have groups of patients with hypertension, you need to include them all across your practice. If you're a single site practice organization, if you're a multi-site organization, that we want you to then report on all your patients across all 20, 15, 10 sites you might have within your organization. So we're not looking, our objective is to look at, as many of our 50, 60,000 treated lives we have, who are distributed across many parts. When it's to providing us with PHI data for patient engagement, there are no changes. We want you to continue to provide as you've been providing for the past 6, 7 quarters, so there are no changes there. But from reporting aggregate data, we want you to then look at the population as a whole. What's uncertain at this stage for us is how this is going to look like when we have spectromedics on board. When we have spectromedics, we'll be receiving your files on a weekly basis in all likelihood. Again, with the same principle, we want to look at the population health so that we can track our activity collectively as well as your activity in more real time. When we have uneducated claims from your practice, we will know what's happening. And we may also be able to receive your information, the structured information as well. In addition to claims, there's a possibility we may be able to get structured data that we can upload to SpectroMedics. So until that time, we will be looking at your system, data coming out of your system as a proxy to see how well we are doing in a real time as well as our PPS is performing. So we want to include all Medicaid, managed care patients across your organization. So, as you know, we need only Medicaid managed care data. We do not need data from commercial patients. You engage additional patients within your practice. As new patients come to your practice, we need to include them as well. So fundamentally, what we're looking for these processes when we report, when we track performance, our performance, we want to include as many of the eligible patients as possible. If you have any questions, certainly feel free to please send us a chat box or email. We'll be happy to have further discussion on what we're hoping to achieve with this.
Next, we're going to move into our clinical projects, first starting with the cardiovascular disease. And Dr. Manjunath and I will kind of go back and forth with these because there are many clinical processes that are influenced with our build or report creation, so that we'll collaborate on these. So the first thing is a screenshot of the cardiovascular disease roadmap that's been used extensively. It was developed by the cardiovascular committee, and it has been used by the EHR subcommittee and many of our partners to identify gaps in documentation and also really let us know what's being captured, what's difficult to capture, and really set out a timeline for capturing these data elements. Also, what you can see on here is we've included ICD-10 codes and any CPT or CT2 codes that would be needed. Next slide. The first metric related to cardiovascular disease is related to smoking cessation. This is relevant for our primary care providers. And again, it's developing a process, but we are asking that you share a roster of 10 unique patients that were referred to the smoking quit line. And again, the reference is the cardiovascular disease roadmap. Next one is high blood pressure monitoring, and again, it's the activity really developing protocols and tools to identify and reach out to patients with elevated blood pressure readings and diagnosis of hypertension without a visit in the past 6 months. So that's really to get patients in for care and to keep their blood pressure under control. Again, this is partner type relevant to primary care practices. So as Dr. Manoff referenced, it's develop protocols within your practices, but to also be able to track the patients and identify those patients that were being affected by this.
Next slide goes into details about what we want for this. So just to orient you, a set of slides, the first slide will go to performance activity and supporting documentation that's outlined in your spreadsheet. But the following slide, in most cases, there'll be a follow-up slide, and we'll identify specifically what we're looking for with denominator and numerator.
Yep. So really, this document is very lengthy, but will serve as a reference document. Basically, all our metrics each have a page or two associated with them. So on this one, again, if you look at it in more detail, it's the activity of 2 or more elevated blood pressure readings in the past year with no diagnosis of hypertension. And then we go further into what patients would qualify for the numerator, and again, the definition of which patients qualify for the denominator. The reference is to the cardiovascular disease roadmap.
So just to focus on the numerator for a minute, here we're looking for the number of patients who had high BP readings but no diagnosis, as well as the number of patients that you followed up. You have 5% of those patients have had no diagnosis, then we would like you to reach out to them, and we want to know how many you were able to contact and bring them for assessment. So we're looking, we're incentivized both for data as well as for a process to improve the data.
The next one is the diagnosis of hypertension without a visit in the past 6 months. These are gap lists. We really want you to evaluate patients who are in your practice who have this diagnosis who have not been seen. Our patients in the denominator have 2 elevated blood pressure readings on 2 separate visits, and an elevated BP is, we give the parameters there. And then the total number of patients seen for a follow-up visit. And this applies to patients over age 18. 85.
And these 2 metrics are directly related to our project milestones that we need to complete by September. That's one of the reasons why we have this built in as incentive. These 2 milestones that we were not able to complete by September of last year, now we have to complete them by September of this year.
And also, if you look at the top, we have the completion date and the reporting date. The completion dates in orange are those that are due in June. Next slide is a standalone metric, and it's again process related, identifying patients that are eligible for at least 1 high or moderate intensity statin therapy based on HEDIS criteria. Many of these outcome metrics, district outcome metrics, align to the HEDIS criteria. So we're asking for supporting documentation is really that evidence that patients prescribed at least 1 high or moderate intensity statin therapy are being tracked and appropriate outreach is occurring. So if we move to the second slide, again, Dr. Manjanoff, I don't know if you want to talk more about this one in general or...
Sure. Many of the denominator, all of these measured denominators we have copied and pasted from HEDIS document. So this is a criteria for denominator. A number of males 21-75, females 40-75 had his MI or procedure or in the previous year for our diagnosis of IBD, ischemic vascular disease, and the measurement year prior. So this is a claims-based measure. So what we're looking for really is from your system to the best of your ability, how can we, if you're able to identify those patient conditions and to see if they were prescribed. From a pure HEDIS, they are looking for dispensing. Obviously, when we incentivize the partners, we do not want to penalize if a patient decides not to go and get the prescription filled. So we're really asking for data on your prescription rather than dispensing, with the hope that 40 to 60% of the patients will get their prescription, go and get their fill, and that will help us to achieve the target. So what we're asking for really from your systems is the prescription information, not dispense information. It is that look at the dispense because they go by the claims data.
So the next metric is talking about providing community-based referrals for patients who have hypertension and cardiovascular disease. So really kind of relying on our community-based partners to really help care for these patients and get them to the right treatment in the community. So again, this is also developing process and referrals within your practices. Again, we've asked for, next slide, a report that shows the number of patients referred to community-based programs from your practice, the number of follow-ups on referrals with documented participation. So again, really tracking the referrals you're making to our community-based organizations and ensuring that the patients are really following up with these. And again, the cohort that will be included for this metric are those patients with hypertension and cardiovascular disease seen during the measurement year. So again, this is a patient registry on a quarterly basis for patients who have been diagnosed with hypertension and cardiovascular disease per any data specifications. And again, as Dr. Manjanoff referred to earlier, really once we get our analytics platform, we'll be using that as well. But for now, we really need to understand our practices and our partners. So if you look at next slide, again, the cohort is all patients with hypertension and cardiovascular disease seen during the previous 12 months.
Just if I may, we're certainly accepting your prior approach of providing a list of patients with those conditions, but at the April meeting, we will analyze what additional components we need moving forward for registry. Look at the CVD roadmap and identify elements that we need to capture as part of our milestone requirements, as well as to track some of the performance as well. So we will expand the registry requirements. It shouldn't be difficult once you have your cohort, once you have your registry approach, be able to get additional data from your system to meet requirement.
And Dr. Raj, one other note on the registry piece is you were submitting them on a monthly basis for phase 1. They've been moved to quarterly for phase 2.
Thank you. Yep. It may not be required once we have Spectrum on board.
Yes. This next slide is patient engagement for cardiovascular disease. Your partners are very familiar with this. You've been reporting this to us for the last
several months.
So this is nothing changed. You should all be familiar with this one. So we're not really going to spend a lot of time on this one. Let's go to the next one. Again, this one refers to demonstrating a process for unscheduled follow-up blood pressure checks for hypertensive patients. So again, we're asking to provide a report for the time period from June 2017 to March 2018 of the percentage of hypertension patients that receive unscheduled blood pressure check. Many of our practices have walk-in blood pressure checks for their patients, so and they are beginning to track those in their EHRs.
Yeah, I'll just make one comment on the patient engagement. If you go back to slide number 29, unlike in the past where patient engagement data was incentivized as a standalone, that's bundled into other metrics. So we need you to engage patients, as many as possible. So we're looking for really some active, the practice level for hypertension project is really providing them with a self-management plan by action. Whatever tool that you're using will be fine. So unlike in the past, for phase 2, engagement will be blended with other metrics so that we are again incentivizing both processes as well as the next outcome.
So for control blood pressure metric, again, numerator is the number of patients that received an unscheduled blood pressure check or a walk-in blood pressure check. And then again, the cohort in the denominator is patients aged 18 to 85 years with a diagnosis of hypertension. And you'll see those codes listed on here, and you'll also receive those with the cardiovascular roadmap. The next one is an aspirin use related metric. Again, this aligns with the HEDIS criteria, and it's a number of patients that received an aspirin regimen out of the eligible patient population based on the HEDIS criteria. Again, this is a claims-based metric that the state reports, but you can also track that with their EHR. Next slide. So again, it's the number of patients that are prescribed or taking aspirin is in the numerator, and the number of patients seen between January and December who are following HEDIS criteria that are defined on the slide. Next one is demonstrating that you are able to capture the 5 A's of tobacco control in your EMR. Many of our primary care practices are already doing this, and we've discovered through conversations with our partners that they may not call it specifically the 5 A's of tobacco control. As long as you can tie the 5 A's to something that's captured in your EHR and demonstrate that to us, be compliant with this metric. We've had some of our partners submit this already for our 930 deliverables in 2016. And the cardiovascular disease committee hasn't discussed it. Next one is, again, about prescribing medication. And Dr. Manj, I think maybe you want to discuss the once daily regimens or fixed combination.
So this again relates to milestone requirement. Our subcommittee has approved the guidelines, Jane's guidelines for management of hypertension. What we're looking for is evidence to show that the guidelines have been adopted at the practice level, and that there are few patients, which I don't think any practice would have any difficulty, because the majority of all of the practices are using this approach for managing patients with hypertension. So we really want the identify screenshot to demonstrate that that's happening in practice.
Okay, the next one is again related to blood pressure control. Again, protocols to ensure that blood pressure measurements are taken correctly, and this is a clinical portion of this metric, and that staff are trained. There are documented EMR fields that you can put the blood pressure in and structured data. So, and the supporting documentation for this is protocols, staining, and again, the key portion of this would be a report aligning with this with the EHR build.
So this may seem a non-EHR metric, but in reality, EHR processes play a major role. If you have not looked at your data across your practice, you may want to look at it, because we've been for some surprises. You'll be able to see some weird numbers, as well as, when we did at least 20 years ago, we had readings 1,240 over 100, depending on how people enter the values. There were text information in those structure fields. In fact, when Hicksney did hypertension analytics as a pilot work 4 or 5 years ago, looking at the data, only 19% of data fields or 20% of data fields that were captured accurately. So there's a wide variation in how data is captured in EHR. So for that reason, documenting accurately the measurements is critical for us for many of them. That's why we have put it as an EHR-related process as well.
And as we stand up our analytics platform, it will be very helpful and important for our partners to be submitting this as structured data so that we can use it for analytics purposes across the PPS. Okay, we'll pause for a minute. Do we have any questions?
We'll give 5 minutes for people to type in their questions, or if you have any questions, comments, we mute ourselves first if need be. So one from our behavioral health partner, 5 A's of Tobacco, safe counseling. They have been doing this. I think it's wonderful. Unfortunately, this metric was related, at least for this activity, related to a primary care practice as part of the hypertension project. So we're not able to get credit or give credit for the best organization activity, but I'm glad you're doing great work. Please keep up with the work. The second question is from relates to, do we have a timeline for spectrometrics? So we're in the process of filing the contract document, file the contract with spectrometrics. We hope and expect that process will be done in the next 4 weeks or so. But in reality, in all likelihood, we're probably looking at third quarter. June is when we think we will be able to start working with the partners. We may work with them before that, but it requires some internal build and understanding what their needs are. So I think from my understanding from the contract signature, they need about 2 months to really prep for our intake and our work. So we're likely during the third quarter of this year, we'll have some those available to us.
Okay, we're moving on to our asthma metrics now. And the first slide in this is also the asthma roadmap, a sample of that which you'll be receiving after this meeting. And many of our EHR committee members are very familiar with this, as well as our asthma clinical subcommittee members. So again, it aligns with the cardiovascular roadmap components, such as the ICD-10 codes and any of the state-required data elements or elements we feel are important for tracking purposes for analytics. And so the first one, again, it's really for hospitals and EDs. We really want to make sure that patients who are discharged are with controller prescriptions, because really our goal for DISRIP is to decrease avoidable ED utilization and hospital visits by 25%. So this aligns with that if you look at the next slide. The numerator is the number of patients that were discharged with asthma controllers prescriptions, and the denominator is the number of discharged patients 5 to 64 years of age with a primary diagnosis of asthma. Again, the reference to this is the asthma roadmap. CPD-10 codes are listed, and the relevant CPT codes are also there. Dr. Mott, anything to add to that? Or do you want to go on to the next one? Is also related to the prescription of prescribing asthma controller medications, again, for persistent asthmatics, really with the goal of decreasing avoidable ED visits and hospitalizations related to asthma exacerbations. Again, the numerator for this is number of patients in the denominator who were either on or received a prescription for an asthma controller medication in the last visit, and the denominator is the number of people 5 to 64 years of age who are identified as having persistent or poorly controlled asthma in the past 12 months. We have given the list of asthma controller medications both in our EHR subcommittee meeting as well as our asthma subcommittee meetings, but again, if you do not have that information, we can get that out to you.
So back to the previous slide, we're looking for 3-month data. And data starting January 2017 to June 2017. So you can choose any 3 consecutive 3 months, and I would like to present the data by July. So my session will be starting to start from February and then go to May. That way you'll be able to provide data by July 10th. Really what we prefer is we want to understand the baseline. The percent of our practice, our systems are able to track this, and it may be happening more often. It's possible practice are not able to give us tracking. That's okay. It doesn't matter what your current performance is. Your performance may be higher than what you would report to us. That's understandable. But we want to set a more of a systematic way to track this activity, key activity, that has an impact on both outcomes as well as paper performance. So we begin the process of identifying patients consistently, using structured processes to identify patients who are poorly controlled or persistent asthmatic, and a systematic way to track to see if they're getting appropriate prescriptions or not. And that's the reason we want to get baseline in July, because some additional activities that will incentivize for improvement later on.
The next one is for primary care providers and our pulmonologists and allergists. Implementing a standardized ACT or asthma control test and tracking the data for at least 3 consecutive complete months between March of 2017 and September of 2017. Really, the goal of this is to develop a baseline, and we'll improve from there. Numerator is the number of people in the denominator with an asthma control assessment using the asthma control test at the last visit. Again, we heard from some of the partners that this activity is happening within the practices, but it hasn't been able to be captured in the EHR. So again, build in some type of process for providers to be able to easily document this so it can be captured in a report would be the goal here. Is for hospitals, ED inpatient, and this is really about developing protocols to make that our patients are filling prescription within 2 weeks of discharge. So really having our ED coordinators, our ED navigators, or our care managers reaching out to patients to make sure that they are following up and filling their medications. Again, this is more clinically related, really doing a root cause analysis and providing the number of patients contacted after discharge. Do you want to add anything to this, Dr. Munch?
When we looked at the data, our data through measurement year 2, we have met or exceeded our target for asthma additional ED visits for children. However, for young adults, our numbers have gone up. So if you're focusing on a group, I would recommend focus on the young adults as well. Make sure that they're getting prescription. The new process, we hope that our EDs, as they begin implementing patient navigation functions within the ED, as part of EDK triage project or other projects, we'll consider adding this specific activity as part of their post-charge processes for patients with asthma, reaching out to them to see if they receive the medication. If there are any challenges with sort of access to medication, please contact us and we can link you up with our health home care MAM agencies. This probably would align with the new state requirement that EDs assess every Medicaid patient coming to them to see if they're health home eligible, right? So with the new process that's going to be in place by May or June, we hope that more of our patients will at least get identified if they have a need for medication adherence support or even access to medication in the community, so our care manager could work with them to see how they can get the prescription filled. Especially if they're uninsured, it would be a challenge because asthma medication, as you well know, is quite expensive. We'll certainly work with our care coordinator to see if we can assist in any way.
And again, on this next slide, we just further define the numerator and denominator for this patient. It would be the number of patients who are contacted for medication adherence support. And for some of the hospitals, this could probably be done within their care management system.
Another question.
Okay.
Do you want to wait until we go through asthma one and then take?
Sure.
Yeah, well, let's finish the asthma one and then take questions.
Okay. Yep, we have a few more asthma metrics, and then again, maybe a little bit more than a few. But once we finish the whole asthma section, we'll again pause for 5 minutes or so to be able to answer your questions. And so the next one, again, as we talked about in an earlier metric, really establishing a baseline for some of our information collected. This one is really, its completion date is actually in 2018, but really demonstrating a 10% improvement from the baseline data that was collected to a goal of 80% or higher rate of asthma control or medications prescribed to persistent and poorly controlled asthmatics. Again, the goal being if medication can be prescribed and filled, that we will decrease avoidable EDs and exacerbations. And again, our numerator is the number who are on or receive prescription for asthma control or medications. And the denominator is patients 85 to 64 years old who are identified having persistent or poorly controlled asthma. And we've included the codes in there. Again, working with some of our practices, we've identified that sometimes providers don't document asthma. They just put an asthma code in there. They don't put poorly controlled or persistent asthma code in there again. Finding some of that baseline data will help identify that in your practice. Anything else to add, Dustin? The next one is also related to persistent and poorly controlled asthmatics. Again, producing structured EHR reports for asthma registry and asthma measures. So we want structured reports from the EMR for asthma registry and applicable asthma measures, quarterly asthma registry template, and sign-in dates for staff receiving training. The report would be registry elements to be finalized at the April asthma meeting. So again, the clinical subcommittee meeting will be re-identifying the key elements that they would like captured in a structured format, and we will be sending that out to you. And again, the cohort is patients aged 5 to 64 with persistent or poorly controlled asthma. Is a quarterly data of, this is the patient engagement requirement that Dr. Manj referred to as part of a bundle again. So all of the patient engagement reports that you've been reporting are now grouped together as a bundle. And consistent with what you've been reporting in the past, again, the existence of an asthma action plan on a patient at their last visit. The next one is, again, I think this relates to where we developed the baseline for the asthma control test, and again, being able to demonstrate a 10% improvement from the baseline with a goal of really providing this test for 80% or more of your patients. And this aligns with what we spoke of with the asthma control test in an earlier metric. The next one is really talks about education and community referral. We're helping educate our patients, our controlled asthmatics, and referring them to either health home or to our centralized care management for a little bit of additional support and education.
Or the referrals could be to a community-based asthma educator, based interventions. I know many of our partner organizations are providing home-based assessment as well as education on medication adherence. Any community-based referral would be applicable here.
And again, be able to track these referrals. We know that from many of our practices, they track their clinical referrals electronically, but again, we can establish processes to track the community referrals electronically as well through your EHR. One is related, again, is this a standalone metric, prerequisite metric it looks like, to identify persistent and poorly controlled asthmatics in the EMR that have not been seen within 4 months of the last visit, and health protocols for outreach. These are these gap lists that we've referred to, and as we stand up the analytics platform, we will be able to identify these patients across our PPS and refer them for care management. But in the interim, our primary care providers and our specialists that interact with these patients, we really would like you to engage those persistent asthmatics that have not been seen. Again, the reporting for this will be the number of patients that have not been seen for an asthma visit over the last 4 months of the last visit, and the number of patients that were contracted to schedule a planned asthma visit. And again, the denominator again is the same as we discussed earlier. So we're going to pause now. We are at the end of our asthma-related metrics, and we're going to mute the line for a second and look at some of the questions that have come in.
And thank you for your good questions. We have 3 questions related to asthma or related to reporting journal. The first question, when you say look back to past 12-month period for reporting, that's look back from the due date, that's from 6/30, look back to 6/30/16. We certainly would leave that up to you. I think that's a very good suggestion. We could set 6/30 if the reporting, if the metric end date is 6/30, looking back 12 months would be fine. The suggestion is once you examine a cohort, set your own internal target as to what the 12 months would be, and look back that way. It could be April 1 through, going back to April 1, 2016 to March 31 could be your cohort, and then you can track. My suggestion would be to use that date frame for all of your metrics when you're developing the 12-month look back. In that way, you can be more proactive for patients in the months of April, May, June. So my suggestion is start from April 1, 2016 to March 2017 as your 12-month look back period. Second question relates to, are we lumping inpatient ED into one group and therefore one report? Yes, that's correct. We are looking for inpatient ED as a hospital activity, one single activity. And the third question relates to, could the EDs fill prescriptions before the patient is discharged to the hospital pharmacy? I'm not sure how many hospital ED systems have that in place at this stage. I know in the past they used to. I believe they have moved away from it, many of the hospital-based pharmacies. But if a hospital or ED is able to do that, I think that would be ideal. So the patient can walk with the inhaler rather than a paper prescription, electronic transmission. But if you don't have that option, it's very understandable. So we're hoping that the navigator would then reach out to the patient or the family to see if they have difficulty in the prescription and reinforce the need to go on the controller as one way to decrease the need for a second ED visit or improve oral outcomes for the patient. So questions on asthma or any slide that we have covered so far?
Okay. Next, we're going to move into our Domain 2 metrics. Some examples of those will be those related to PCMH, our 2AI integrated delivery system, as well as our Health Home at Risk project. The first is standalone metric, and this is very important with our population, that want evidence that a evidence-based health literacy screening tool that we will provide is being implemented and used in a daily practice. Again, the supporting documentation of this will be 10 identified screenshots showing use of the screening tool and the results of that. Next one is related to our patient engagement and experience surveys that are sent out. And again, Chrissy, do you want to speak to this one?
Sure. So this is a standalone metric, and it's basically for the primary care organizations. Many of our performance outcomes are tied to the CGCAT data that the state provides to us in terms of relation. So this is the CGCAT, the patient experience for the uninsured population. So what we need is the uninsured population list in order to do that. I'm going to go through this really quickly, sorry. So what we're looking for from you is at least 3 consecutive completed months of patient experience data reported to us.
The next one is for EDs and hospitals. Again, it's implementing and adopting the LACE tool. Again, this is a tool that predicts a patient's likelihood for being readmitted. I think some of our partner hospitals have already adopted this and have shown a lot of success with these numbers. Again, so we are, for supporting documentation on this, really updated protocol. And then the IT component of this would really be the roster of patients with a LACE score of 10, higher than 10 for all patients available since April 1st of 2017 and September 30th of 2017.
So I'd like to just make a comment on our high performance metric, this high performance metric, potentially preventable readmissions. Our PPS is not doing well. We're at the bottom of the 25 PPSs for performance on this. In fact, our numbers are going the wrong direction. We're with hospitals at least to see what we can do within our resources to help them impact these numbers. For our Medicaid population across, this based on the data we have through June of 2016, now we have June of 2016 data. In fact, it's going in the other direction. So part of that, what we're looking for is some additional activities at the hospital level, whether ED or inpatient, to be proactive when it comes to Medicaid patients to see how, looking at some evidence-based approach to impact these readmission rates. I really want to congratulate Saratoga Hospital System who have implemented LACE. Our understanding is back last fall, they started using LACE as part of their discharge planning process, both ED as well as inpatient. and they've apparently seen some good results in this process. So we're asking hospitals, and we're again meeting with the hospital leadership as well as directors of case management, and we're also looking to bringing together 3 hospitals to a table to share best practices as well as challenges to see how best we can impact. Most recent data, Saratoga County does well, given their perhaps demographics. Albany and Greene and Columbia counties, we have a significantly high readmission rate for Medicaid patients based on the data through 2016. We'd like to work with you, at least to see what we can support. We're engaging health homes, engaging care management agencies to offer additional support for you. Certainly, we'd like to and to see if there's any additional activities that could be implemented at the hospital. Thank you.
Okay, and the next metric is also related to preventable readmissions. And this is tracking dictated discharge summaries to ensure that they are within 48 to 72 hours after discharge, and really running a report to see a sample of 50 inpatients discharged who follow-up providers have been sent the dictated discharge summary. Again, we understand from certain systems if the discharge summary has been dictated but not signed, it's not available to be sent to the next provider. So we really would like our partners to take a look at this process within their organization.
Sure. For Mark, because of the short time, and we said that are very low. I'm sure all hospitals are providing discharge summaries, and we just want to list a random list of 50 patients who were given discharge summaries, and with provider PCP identification. The next slide is a good example of what we're hoping to see, but we certainly didn't set that expectation. For this report, all we need is discharge date, when was the date of dictation, date sent, and the PCP name. But I want to highlight the work Columbia Memorial Hospital leadership has done. Both Dr. Pearl and Dr. Paul, working with the IT, are able to now track by provider, by hospital, by provider, their activity related to discharge summaries. So they have an Excel spreadsheet that looks at discharging provider name, the discharges provider was responsible for, and average time from in hours from discharge to transcription, and the number of how many times they were able to complete the discharge summary after 72 hours, and percentage-wise. So they have some very interesting data. There are about maybe 150 providers. And I believe some are doing a great job. Others need some help. Now they're now able to go with the data and meet with the clinicians and counsel them and work with them to see how best their performance could be improved. That's, I think, will be in a way, because as we heard quite loudly from our primary care partners when we had the Accenture One Group meeting last year, people want this short summary. If you really want them to take ownership of these processes, transitions of care, and do more at the primary care community level, it's very important they get the discharge summaries on a timely basis. Use electronic mechanisms, RIXME or others, whatever the process that you can look at, we want those to go to PCPs on the basis. Thank you.
One is related to Project 2AI. Again, we spoke about this in some of the earlier metrics. There is going to be a state requirement for a hospital to refer to health home for those patients who are eligible. And also, for our centralized care management, Benny Cares, we would also like to receive referrals, and we'll move on to the next slide. Really, a report of health home eligible patients referred to health home for services would be one thing. And then those patients with only one chronic disease that are not eligible for health home services that are referred to Benny Cares or managed by a PCMH site for care management services. So really connecting those patients that need a little extra care with care management services out in the community. Next one is for the Health Home at Risk Project. Again, for primary care. A quarterly report of all care management plans is outlined in the patient engagement definition. And Benny will be providing a template for this and data specifications. So again, this is a patient engagement.
So this is a patient engagement metric. It is the same report that you've been reporting over the past several quarters. DOH has provided some additional guidance for this specific patient engagement definition. So although the definition doesn't change, in the template that I'm hoping you're all familiar with, they've provided some additional bullets on that clarifying information that I believe should help. But if you still have concerns, I'm pushing those questions back to DOH for more clarification if needed. The other things on patient engagement that I do want to point out, because it's a bundle, a report of 0 does not count. There's also the submission of 4 out of the 5 reports. So you'll see the completion dates and the reporting dates above. We want to have at least 4 reports submitted in order to be eligible for this metric as well.
Related to this, at the subcommittee level, we have finalized the elements that need to be captured in a care management plan. I want to thank and congratulate many of our primary care partners to go back to their processes and to make modifications to their existing care plan to be able to meet the DOH requirements for the care plan need to have. So we have finalized, and we do have a paper copy that our health subcommittee has approved. I would share that we want to increase the number of patients who are engaged with these processes. We really need more care plans, and that's certainly what we'll be bring as part of our patient engagement.
Okay, the next one is related to hospital ED departments and really compiling a list of high ED utilizers so that we can refer them for care management services and really understand the patients in our PPS that are utilizing the ED. Again, as we've referenced earlier, when we are with our analytics platform, we will be able to track this as well across our PPS. So it would report of patients with the definition is 3 or more visits in the previous 6 months. Then the denominator is all patients seen in the ED. The next one is quarterly data for appointments with a PCP as outlined in the patient engagement definition using the Benny provided template.
So for the ED Care Triage project, the definition does not change for ED Care patient engagement, One of the things that you'll notice is that we're focusing on the primary care providers in this piece. So it is the total number of patients seen in the ED with 12 months and have a follow-up PCP appointment scheduled within 30 days of that visit to the ED. Many of these reports last quarter or last year were coming in from the EDs saying that a patient was seen in the ED and they were able to look at their primary care records as well to see that there was appointment scheduled. We are now looking for primary care providers to say that their patient was seen in the ED and appointment or follow-up appointment was scheduled with that primary care provider within 30 days of that visit. So all looks the same, but we'd like the primary care providers to be tracking this information as well.
The next one is related again to our primary care practices, and it involves patient education, really specific to what a disease or needs that the patient may have. Many EHRs will suggest specific educational resources, but again, we just want an example of resources or tools or aids developed for self-management and support their decision-making activities.
So the 5 metrics we have for incentive rate of PCMH, they come directly out of NCQA 14 standard. All these are must-pass elements. We have signed agreement with Haney's. They'll be reaching out to our practice of partners to begin engagement. So when we look at the various elements and factors that need to be captured for each of them, and we identify maybe 3 or 4 for each standard, each element that we thought we could include for incentive that would the control of your practice. So as you're working through your, you've already done insecure work, there should not be any different or challenging. We really want to be able to see that our practice is able to sustain those PCMH-related activities, functions, on an ongoing basis. That's why we decided to put some incentive for that activity. That's what I think standards for, I believe.
Next, also PCMH related, and it's really just providing us with a sample of 5 care plans that have been developed in collaboration with the patient family using a standardized template. So many of our practices that are already PCMH certified have been doing this, and we did meet with one of those last week, and we went through their care plan that they've developed. So, Dr. Mons, do you have anything else?
No, this is one way you can earn incentive for 2 metrics for the same process. If you're a health home and you're doing a care plan, the same care plans are also applicable for PCMH requirements. Having that comprehensive combined care plan meet multiple needs, so be able to do it.
And the next one is related to flu vaccines for patients. So the number of patients that receive flu vaccines out of the total eligible patient population from September 2016 to March 2018. And again, to track these patients in the EHR, and that should be pretty easy for most of our primary care practices. Dr. Mons, anything to add?
No, I just want to go back to them. We just highlighted 2 of the 5 PCMH metrics. They have some EHR relevance, but the 2 additional, that's also as part of your overall contract package, additional measures related to PCMH. On chart, we're hoping that if a patient were to provide information that they had received the flu vaccine at the pharmacy level, that you will be able to embed as part of the EHR structure template. I know from a payer perspective, they get their claims from the pharmacy, they get more comprehensive. The practice level that can be challenging because many patients get their flu shots elsewhere at work or at their pharmacy. But if you're able to capture as part of the immunization structure data system, it would be helpful. First look at more comprehensive nature of our population.
I think our last metric for today,
Oh, wow.
I can't believe we got through all of them, is really developing a comprehensive medication reconciliation process and to incorporate that as part of every visit. So really going back and reconciling the fill history and really kind of working with the patient so that you have the most up-to-date medication list for the patient. Dr. Mons, have anything?
No.
So just to recap, we thank you for your patience.
A couple of questions.
Oh, we do have a couple questions.
We're here till 10:30. Certainly,
Yep.
if you'd like to send us questions, we'll be happy to respond to them.
Unmute it for now.
Yep.
Just need to go back to the stacking question that Doc Jones. Here's the number, 01.
Can you mute
just had mute ourselves so that we can go through the questions. I'll go through the questions one by one and to see how we can respond to, and we may need to have some offline conversation on some of the questions. The question was, do we have a shorter patient satisfaction survey tool than the one chosen? The patient satisfaction surveys, we are not responsible for sending the surveys out to majority of patients. The only group of patients that we are responsible as the PMO are uninsured patients as part of 2DI. All the patient satisfaction survey data really will come directly from DOH. DOH will work with the vendor and provide them a list of anywhere from 1,500 to 3,000 patients, depending on the size of the PB. And they get the data, they analyze it, and they let us know as to how well we have performed on any given year. So we can move away from the traditional CG caps for primary care-based practices. If you have additional tools, certainly you're welcome to use it, but for our needs, we will be looking at CG caps. And the question on statin therapy, we'll go back to the personal question, some clarification, because we're not clear. If you please give us more information as to what specifically you're looking for in the statin therapy. And a clinician has some very good suggestion on really working with our hospitals, EDs, to assure and to make sure that the medication reconciliation process and the discharge medications are consistent with current medications. I think there needs to be some effort on the part of hospital system to look to see what the patient are on, either from the PCP records or a HCME record, so that there's alignment between discharge medications and patient's current medications, because apparently it's creating necessary readmissions to the hospital because of inconsistency in medication. I think that's a huge challenge. It's a very important one. We'll certainly work with hospitals to see how best we can. So the next question is an important one as well. Many of the elements in the care plan template are typically captured in the EMR, or patients are not signing them. The signature piece is a requirement DOH has for care plans. So we have our care plans completed at the primary care level, or the PCMH, or the health home agencies. We'll strongly encourage that the care plans get reviewed with the patient and signed if possible. But our project milestone ended this year, but however, because this is patient engagement data, DOH could come back to us at any time and ask for a sample of care plan that we have provided as part of our engagement. So when we do that, we need to be able to demonstrate to them that what we are submitting meet the DOH requirement. So we do that to the practices, but our suggestion is to the extent that you can have them printed plan with the format that we provided with a signature would be helpful. Question, but certainly if you have additional clarification, please email us. Sorry about the confusion. We had muted ourselves here, that's why you were not able to hear us. This metric that requires an office with a documented phone visit with patient count if done by provider. Certainly it would count. It depends on the activity. If you are in proactive outreach to patient to engage them with the phone call, I think that's fine, even though it may not be billable with it. As long as the activity is taking place and you can demonstrate that you have done outreach. And we did that pilot for we were as part of doing, we did telephonic ACT score at some point, as well as telephonic post-visit follow-up to see if they had any need for medication. So I think that's very appropriate as a link contact the patient and there's meaningful exchange of information during that phone call visit.
Dr. I can help with the next one quick with the clarification. So thank you, Doc, for your clarification. And it does look like the slides that went out, 23 and 24 should be activity ID P016, and then P10 was found later on in the presentation on page 66. So we will send out updated slides for you, but for anybody that's taking notes, slide 23 and 24 refer to activity P_016.
The next question is, where can I find a copy of the approved care plan? We will email that to you. Certainly, email us back, and we'll be happy to share with the approved care plan. Send an email to Disrupt, and we'll send you the care plan. Thanks for asking. Any other questions, comments? We all need your feedback on the format that we used for this morning. Dr. Rohr, certainly your suggestion was a very good one. So as a group, let us know if you need to make any changes for April 17th. At that time, objectives are to review, be part of a regular EHR subcommittee. We'll review the draft elements of the behavioral health roadmap that we will want some feedback. As you the behavioral metrics, there are quite a few behavioral project metrics. Linkages to EHR. We'll do them. And time permitting, we may review additional behavioral metrics and go through an entire spectrum of behavioral metrics, not just related to EHR, the set of behavioral metrics as well as the April 17th meeting. So answer any additional questions folks might have on any of the core metrics. We'll be happy to provide information. This is helpful, certainly provided feedback, and again, I want to thank our team for the hard work in putting together this presentation in a very short time, and thank you all for being with us this morning.
Yes, and please remember to email us your attendance from the link, in the link provided in the,
in the meeting invite and on the attendance slide. We're going to be taking attendance for meetings a little bit differently this quarter. It's a very simple survey asking for your name and organization. The slide also provides the name of this meeting that you're attending. So just let us know if you have any questions on that. You have received that. And we're going to be sending updated slides. Recording will also be available for anybody else in your organization that you would like to hear this meeting.
As the contracts are finalized, we'll be sending out an Excel spreadsheet with a list of all the IT-related metrics.
All metrics.
Yes, all metrics, and then sorted and color-coded for the IT metrics so that you can use that.
Great. Thank you. Send us questions